Hello everyone, welcome to 5 Mark Short Notes series. Today we will discuss about senile vaginitis, that is atrophic vaginitis. So what is senile vaginitis? It is inflammation of the vagina due to postmenopausal estrogen deficiency causing dryness, irritation, discharge and pain. So physiology. So before menopause, in reproductive age women, estrogen keeps the vaginal epithelium thick, elastic, moist and rich in glycogen. Glycogen supports the growth of lactobacilli, which produces lactic acid and maintain vaginal pH in the range of 3.5 to 4.5. This acidic environment protects against the infection. Whereas after menopause, estrogen levels falls drastically. Therefore, vaginal epithelium becomes dry, glycogen content decreases, lactobacilli population also drops. Therefore, the pH rises above 5. The tissue becomes fragile and more susceptible to trauma as well as infection. The set of changes collectively predisposes to senile vaginitis. So, what are the etiology? First is natural cause, then surgical or medical menopause, then premature ovarian failure, then anti-estrogen medications. Natural menopause is the most common cause. So after midline hormonal transition, ovarian estrogen production declines sharply. Surgical or medical menopause, that is bilateral oophorectomy, chemotherapy, radiotherapy. These causes abrupt estrogen withdrawal. In case of premature ovarian failure, this might be due to autoimmune disorders, genetic causes, or idiopathic factors causing early decline in ovarian function. Anti-estrogen medications like tamoxifen or aromatase inhibitors might also cause a senile vaginitis. So, pathophysiology. So, there will be thinning of the stratified squamous epithelium, followed by loss of elasticity, which results in reduced lubrication due to decreased transudation. Microabrasion and inflammation results in which causes loss of acidity, which results in increased susceptibility to infection. The vaginal canal may shorten and narrow, and the introitus may contract due to loss of collagen and elastin fibers. Clinical features include vaginal dryness, burning sensation, itching, dyspareunia, foul smelling discharge, spotting or postcoital bleeding due to tissue fragility. In case of genitourinary syndrome of menopause, there will be increased frequency, urgency, dysuria, recurrent urinary tract infection, sexual dysfunction. In the examination, you will find a pale, dry vaginal mucosa, loss of rugae, pinpoint hemorrhages or small erosions, narrow introitus, atrophic cervix, and elevated vaginal pH of greater than 5. Diagnosis is mainly clinical and it is based on postmenopausal status, typical symptoms, and physical examination of the vagina. The investigations include vaginal pH testing, which is if a pH is greater than 5, it usually supports the diagnosis. Parabasal cells reduces lactobacilli and increases inflammatory cells. Culture if infection is suspected. Pap smear to rule out malignancy in cases of bleeding. Differential features. Candida vaginitis. There will be thick curdy discharge and intense itching will be present. It is differing because the discharge will be very thick instead of watery, and the pH will be normal or low, and there will be pseudo hyphae in microscopy. Bacterial vaginosis, there will be fishy odor, thin gray discharge, clue cells will be present, and pH will be elevated, but no atrophy will be seen. In case of trichomonas vaginalitis, frothy greenish discharge and strawberry cervix will be present. Motile trichomonads are visible with a more profuse discharge. Lichen sclerosis, there will be white patches and parchment-like skin. It affects vulva more than vagina and autoimmune pattern. Contact dermatitis, burning, itching after exposure to irritants, clear exposure history to soaps and detergents. In case of foreign body, foul smelling discharge and spotting will be present. Localized irritation and removal provides cure. Vaginal or cervical malignancy may result in bleeding with a foul smelling discharge, and there will be a mass lesion that will be present, and it requires biopsy to confirm the diagnosis. So, what are the management? So, avoid scented soaps, harsh detergents, or irritants. Use non hormonal lubricants during intercourse. Maintain good perineal hygiene. and adequate hydration and cotton undergarments. Local estrogen is the most effective therapy because it directly restores the vaginal epithelium. The forms include vaginal estrogen cream, vaginal tablets, and estrogen release ring. Benefits include improves the lubrication, restores thickness and elasticity, lowers the pH, restoring normal flora, relieves urinary symptoms, minimal systematic absorption, safe for most women. Coming to the systemic estrogen therapy, the patient has bothersome menopausal symptoms like hot flushes, night sweats, in addition to vaginal symptoms. They require concurrent progesterone if uterus is intact to prevent endometrial hyperplasia. Non-hormonal moisturizers. For women who cannot use estrogen, example, there may be some breast cancer survivors. For them, polycarboxyl-based moistures, hyaluronic acid gels are suggested. These provide symptom relief but not necessarily reverse the atrophy. Coming to the management, sexual counseling is very important, useful for couples experiencing pain, anxiety, or reduced intimacy. Newer therapies include laser therapy, vaginal CO2 or ERAG laser, vaginal DHEA. So complications include chronic dyspareunia, recurrent urinary infection, fissures and vaginal bleedings, emotional distress and sexual dysfunction. Rarely, atrophy may cause severe stenosis of the vaginal wall. To summarize, senile vaginitis or atrophic vaginitis is a common postmenopausal condition caused by estrogen deficiency. It leads to thinning and dying of vaginal epithelium, loss of protective lactobacilli, a rise in vaginal pH. These changes produce symptoms such as dryness, itching, burning, dyspareunia, watery discharge, and postcoital bleeding, and then urinary complications like urgency and recurrent infections. Examination shows a pale, fragile mucosa and loss of rugae. Diagnosis is largely clinical, supported by elevated vaginal pH and microscopy showing parabasal cells. Treatment focuses on local estrogen therapy along with lubricants, moisturizers, and avoidance of irritants. I hope this is useful for you. Thank you.